Hospital. And the talk today was going to be a case presentation that we thought was interesting on a patient with FMD and then a literature review and discussion. So I'll hand it over to Asim when he's ready.
Okay, good evening, everyone. Thank you for joining us this evening. I know it's a public holiday in New South Wales. I'm Asim Khan. I'm the transplant fellow at Royal North Shore Hospital, and I'm in my second year of PFIT training, and I'm privileged to be working with the vascular team at the Royal North Shore Hospital. Today, I'll be talking about a case of a deceased donor transplantation who had an intra-op diagnosis of FMD and how we managed it. So I'll be just going through the case presentation, a brief overview, a review of literature, and a conclusion from my side, and I'll open the floor for discussion. So we had a 24-year-old male patient who underwent a deceased donor transplant at Royal North Shore in mid-January. He had a background of mild intellectual disability due to a chromosomal deletion with a short stature, mitral valve incompetence, previous failed PD dialysis due to a pleuroperitoneal fistula, cardiomyopathy, pneumonia, preoperative hypertension, hypercalcemia, and hematuria with no obvious cause found. So he was on hemodialysis for roughly about 4 to 5 years, and he was on hemodialysis while his permacath, because of his fistula being aneurysmal and it was due for a revision at the time, it was later ligated. So on the day of the transplant, we performed this transplant in the middle of the night, and roughly about 24 hours prior, he had his session of dialysis with a preoperative creatinine of 559. So, I mean, upon induction, he had an anaphylactic reaction to cefazolin. He was hypertensive with a systolic blood pressure of 60. He had a rash all over his trunk and limbs. He was treated as anaphylaxis with a good response to adrenaline. And there was a fair bit of discussion with the anesthetist, the renal physician, and the surgeon. And the decision was to proceed ahead, given the amount of time that he had already waited and the fact that it was a very good match. So we got the left kidney with the 4 out of 4 perfusion. There were 2 arteries with the main and the accessory on a caral patch, 1 vein and a ureter. And we implanted it into the right iliac fossa using the standard technique, which is the end-to-side anastomosis of the caral patch to the external iliac artery. And our warm ischemia time was 25 minutes. I've got a number of people right in front of my screen that is a little bit distracting. So I'll just try to just move this out of the way here. And I'll just review my talk again. Can everyone still see my talk?
Yes, Asim. Yeah, it's still on the same slide.
Okay. Sorry, it says it's paused on my screen is being paused. 1 second. Sorry, there was something wrong here. Wait, just 1 second. Thank you.
We can see your cursor moving.
Okay, all right. I'll just keep moving. Thank you very much. Sorry about that. Very good. Thank you very much. Sorry about that. Okay, so we have an intraoperative protocol. We've got an extensive ultrasound protocol wherein we've got the sonographer on call coming into theater after the anastomosis, and we use a sterile hockey stick probe to examine the anastomosis. And we have devised a protocol that we recently published in the Journal of Medical Radiation Sciences this year. So our protocol consists of using the hockey stick directly over the anastomosis. In case if there are two anastomoses, we look at both anastomoses, and we perform a duplex. And then we move on to look at the renal vein, followed by the clamp sites, both the proximal and the distal clamp sites, and finish off the ultrasound by looking at the resistive indices in the upper, middle, and lower poles of the kidney. I mean, once we have done this, we normally do an additional duplex after the ureteric implantation and positioning of the kidney, as well as after closing of the fascia and before closing the skin. So upon this routine ultrasound investigation, we discovered not a tight, I mean, a rather significant stenotic lesion in the main renal artery supplying the upper pole of the kidney. And it was interesting to find that the accessory renal artery, the accessory renal artery was well perfused, widely patent, with the normal RIs in the middle and the lower pole. However, in the upper pole, the RIs were very low. As we can see on the right-hand side, this is the intraoperative duplex with the gate in the most stenotic portion of the artery, and angle corrected. And we can see that the peak systolic is about 387, with a resistance in the index of 0.41, and there is considerable aliasing and spectral broadening on the duplex. And this was the first time that we thought that there might be something going on here. It is most likely, it looks like a stenotic lesion, very suspicious for FMD. So yeah, I mean, we took further pictures there. As you can see, there's quite a lot of aliasing again on color duplex, as and a fair bit of spectral broadening as well. So I mean, at that time we decided to treat the lesion at a later time, and we completed the operation. Given the time of the day, it was roughly, I think, about 4 o'clock in the morning. Now Dave, I mean, intraoperatively, he had received about 8 liters of plasma light, and we have a departmental protocol of not giving any mannitol or furosemide. We just gave heparin as a standard. He had good urine output. I mean, he had native urine output prior to the operation. Day one, his potassium was quite high. It was 6.9, and the decision was made to dialyze him. So he went for dialysis. So that's the creatinine starting in its low 600s, sort of like creeping up to a 700 when he had the dialysis just immediately after the operation. And so obviously his creatinine dropped down. But again, there was quite a bit of a steady increase going on from there, basically. So I mean, we do have a duplex protocol post-operatively as well. So we normally scan all our patients in a vascular laboratory on day one, again on day 3, and again on day 7 prior to the discharge. So this is basically the vascular ultrasound duplex report from day 1. Which clearly shows the stenotic lesion in the mid pole of the main renal artery, supplying mainly the upper poles and the middle poles, and the patent renal accessory supplying the watershed middle and lower poles. And we can see, I mean, although, I mean, this phenomena wherein we see a discrepancy in the RIs, I mean, the RIs usually tend to go up on day 1, and they sort of like tend to become more normalized towards A7. And this was also published in one of our more recent papers. But the fact that there was a tight stenotic lesion with a peak systolic of 429, we decided to treat this lesion with a balloon angioplasty. So we took the patient to theater on day 3. Patient had a general anesthetic. We did a bilateral groin puncture. And then we used, 4 French micropunctures on both sides and upsized to a 5 French on the right. And on the left, we upsized to a 7 French with an up and over sheath. We administered 5,000 units of heparin, and the patient received a total of 50 mils of dilute contrast. Now, we do perform intravascular ultrasound. So I'm sorry, I don't have pictures to share from the intravascular ultrasound, but we did confirm our duplex as well as our angiographic findings with the intravascular ultrasound. So this is the on-table angiogram. This is the external iliac artery, and then we've got the catheter just parked just at the origin of the main renal artery. And as we can see, we've got the surgical clips here, and we've got the tight stenotic lesion here, which is just here, with a post stenotic dilatation. So this lesion was crossed using an about Ironman wire and 014 wire. We crossed this lesion successfully. And we treated this lesion using an Abbott Wiretrack 14 plus peripheral dilatation catheter in successive dilatation. So this is just a plain balloon angioplasty. And we used a size 4 first, followed by a size 5 and a size 6 at 20 millimeter balloons, with the completion run showing an excellent result, as you can see. So probably this is the start of the artery, but you can see that almost it kind of like matches up with the post-stenotic dilatation and is as in the completion run. So we performed, because that was a day 3 when we performed the intervention, we just delayed our usual protocol. We modified it a little bit and did a duplex the next day. So this was the day 4 duplex here. And as you can see, the stenotic lesion that we had noted earlier in the main renal artery was now gone, with a complete or near normalization of the transplant renal artery velocities here in this region. And I mean, these RIs are still considered to be high. I mean, 0.5 to 0.65, and that's what we aim for, and we expect to see when sort of like reaches like 0.8, they're slightly considered to be more high. And I'll show the next one that we have. So in terms of creatinine, as we can see, we had a steady drop after doing the dialysis, and the creatinine. So we did the angioplasty somewhere here. This was where we did the balloon angioplasty, and following the balloon angioplasty, as you can see, the creatinine kept dropping, and the patient did not require any further dialysis. Sorry, and the eGFR sort of like just increased at the same time. And this is actually a 6 months follow-up. So it's from January basically to August. And as you can see, with the initial rise in the fall, it has sort of like continued to maintain itself with almost a near normal creatinine level and normal eGFR. So I thought, I mean, based on this case, just to discuss a few case reports from literature and just to understand a little bit about what FMD is. I mean, I won't go into too much of detail, but I'll just go through some of the pertinent facts and some of the key points that probably we need to know as surgeons. So fibromuscular dysplasia is a relatively frequent arterial deformity. It is non-inflammatory. It's usually segmental, focal, potentially it could be multifocal, and it affects small to medium-sized arteries, which may lead to a stenosis, a dissection, or an aneurysm of the affected vessels. And usually the arteries that are affected are usually in the head, the carotid arteries and the vertebral arteries, renal arteries, or for that reason, any other arteries in the body could be affected. The etiological factor is mainly unknown. The prevalence of FMD is suspected between 2 to 3%. Potentially being diagnosed more in the living donors because the living donors tend to have preoperative CT angiograms. In terms of the classification, I mean, things have evolved since FMD has been first known. Historically, it has been classified according to the intimal, medial, and adventitial types. However, we have actually moved away from this classification, reason being not all FMDs are resected, and FMDs are now being treated using vascular intervention techniques. So we actually don't get a histological diagnosis until it's resected. But obviously in the intimal type, it's a growth within the intima. In the adventitial type, in the medial type, it's mainly deposition of collagen in the medial layer. And in the adventitial or the perimedial type, it's mainly the adventitia that's affected, causing narrowing in the artery. So a more plausible and a sensible classification came from the FMD consensus conference statement that introduced the use of angiographic classification and basically defined it as focal or multifocal types. Now, I must say I took this picture from the FMD American Society website. So basically a normal artery, focal dilatations here, showing the string of bead signs, and aneurysmal degeneration, arterial dissection, and intimal disruption here. Sorry. So FMD is typically characterized by multifocal changes, as such is described by a string of bead sign, with alternating stenosis and aneurysmal dilatations. I mean, more recently, this is from one of the urological papers published in 1999, and these authors have basically graded the FMDs from 1 to 4, and this is on the basis of the presence of unifocal lesion, multifocal lesion, associated arterial narrowing, and associated aneurysmal degenerations. And I mean, these authors have described that usually grade 2 FMDs, I mean, I mean, in living donors, I mean, usually authors, they prefer or tend to accept it, although this could be debatable. So given that I've just done I mean, one of my colleagues from the unit actually did a literature review, and I've taken a consent to speak about the limited case series here. So I'm just going to talk very briefly about the reported case reports in literature, and these date back to 1984. So it's basically over 40 years. And we have a total of 19 case reports, totaling about 39 patients. And out of the 39 patients, understandably, 29 patients are living donors who had a diagnosis of FMD on a CT. And 10 patients were deceased donors, and only 8 of them had a vascular intervention. So I'll just go very briefly through each of them very quickly. The first dating back to 1989 with 3 case reports. And here, I mean, the FMD was diagnosed during retrieval, and all the 3 patients had prophylactic resection with a good outcome, at least at the first year. And there is nothing reported beyond the first year. The second case series consisting of 4 patients, again in a living donor, and this was diagnosed preoperatively, again treated with a resection of the affected segment, again with a good postoperative outcome in terms of normal or near normal creatinine afterwards. The third one in 99 in a 44-year-old in living donor with FMD in the proximal segment, again treated by resection and reconstruction. Again, a normal value at a year. Again, after the millennium, when there were again a case report from 2002, with two patients, again living donors. Here, the patient had a venous graft resection of the affected segment, and again there was an end-to-end a reconstruction and a take back with the resection of the segment and using an interposition great saphenous vein graft. And the authors have reported a good outcome at 27 months. Again, the second one in a 62-year-old, again a pre-op diagnosis, again had a resection of the affected segment and had a good follow-up and a good outcome at 23 months. In 2002, another case report in 35-year-old, again a living donor. Again, here the patient was treated with a resection, and again a venous interposition graft was used with a good outcome at 6 months. Again, coming to 2012, this is a case series, a large case series of living donors with preoperative diagnosis. Here, some of the patients had single arteries and some of the patients had double arteries, again treated with resection. Sorry. Again treated with the resection, and four patients, they were, they had normal creatinine at follow-up. Three of them had mild hypertension. 2014, again, an observational study of 5 patients, again in living donors. 2 of them had resections, and 3 of them required an interposition graft with no specific discussion about the hypertension or creatinine. 2019, there was a case report again, a 31-year-old. Now, this was in a deceased. It was diagnosed intraoperatively, and it was in the proximal segment. There was a resection of the affected segment with a good 5-year result at follow-up. In 2020, again, a case report in a 50-year-old male, a living donor, again, FMD in the proximal segment, had a resection of the affected segment with reconstruction using the patient's internal iliac artery. Again, a good result at 3 years. A case report from 2020, FMD in a 25-year-old, again, a living donor, and the patient had disease in the mixed segment, which was interesting, and a prophylactic resection of the affected segment, and patient had a cryopreserved iliac artery graft from a deceased donor. Again, day 5, a good result with a 9-month follow-up, again reporting a good result. A recent case report from 22, FMD in a 63-year-old in a deceased donor, and this was diagnosed intraoperatively. But here the patient was treated with a resection of the deceased segment with a good result at 1 year. Now, so those are all the cases that I discussed earlier. Those are all cases where patients had resections. They had patients were treated operatively. Now, the next case series that I'm showing you, it's very limited here. These 8 patients, they all underwent balloon angioplasties, and some of them had hybrid procedures. The first, interestingly, dating back about 40 years ago in 1984, 36-year-old male. Again, this was in a deceased donor with disease in the proximal and mid segments. Angioplasty at the time failed with an open exploration, a resection of the artery beyond the stenosis and reanastomosis to a hypogastric artery. However, it looks like the kidney was lost to rejection. The next report in 96 in a 28-year-old in a living donor with FMD in the distal artery, had angioplasty at 2 years and again at 4 years with good results. More recent one in 1999 in a 33-year-old male, and again in the deceased donor kidney with a disease in the proximal renal artery. Interestingly, here the original lumen was occluded by the dissection, and the smart vascular surgeons, they basically did a subintimal entry and dilated and used a metallic stent with an excellent 1 week follow-up and a good result at 15 months. Again, in 99, a 44-year-old in from kidney from a deceased donor. An FMD in the proximal segment had a successful balloon angioplasty. And again, a similar result in 2003 with a good reported outcome at 2 years. In 2006, this was in a living donor. Here, the patient basically underwent prophylactic nephrectomy, performed distal to the stenotic area with an enterococci anastomosis. The patient was treated with angioplasty earlier, but however, I think that failed. So that's quite interesting there in itself. Another case from 2014, a 44-year-old with kidney from a deceased donor and diagnosis at 3 months, treated successfully using balloon angioplasty. And a more recent one in 2020, a 41-year-old, again from a deceased donor, with FMD in the mid to distal segments, again treated with balloon angioplasty using a 5 mm balloon, and a good outcome at 12 months. So basically, based on this literature review and based on this level 4 evidence of case reports, we can say that patients have undergone resection of the disease segments and anastomosis with good outcomes. Some of the patients have undergone, although from the 39 patients, only 8 patients underwent a balloon angioplasty. With one of them had a fit, I think had a bad outcome, but however, the 7 of them had a good outcome with the balloon angioplasty. However, all these patients, they had the diagnosis of FMD afterwards. Even the one that was treated using vascular intervention was diagnosed for the first time after 17 days. We report a case, wherein we diagnose FMD intraoperatively, and I think probably this is because of our extensive ultrasound protocol that we use at Royal North Shore Hospital, and we treated it in the first week with a good outcome. But however, in our case, this was a unifocal FMD that we treated using balloon angioplasty, and the creatinine needs to be, and the creatinine remains stable, and probably we'll have to just see over the next period of time how this behaves. But I believe that probably, I don't know, maybe the patient might require another balloon angioplasty in a couple of years' time. So thank you very much for your attention, and I would like to open the floor now to the audience to describe their experiences in diagnosing FMD and their experience in managing FMD.
Thanks, Asim. Great talk. Did anyone have any questions? Oh, yeah, I can see a hand up. Hi, Santosh.
Yeah, can you hear me, Animesh?
Yeah.
Okay, thanks, Asim. That was a very interesting talk there, because one, I was surprised at the number of cases that you guys have collected over a period of so many years. So that's very interesting. But this particular patient that you presented, now you guys have been doing the intraoperative Doppler for some time now, isn't it? At least from 2020 or even before?
Yeah,
That's right. Yeah, please, Anish, go ahead.
Yeah, so when you initially did the ultrasound, didn't you not pick up the unifocal FMD on that superior pole artery? So that was missed, or it was just that it was decided at the time that you were definitely going down the PTA plasty route, or was it missed and then after you closed up the patient, then the scan picked up something, the FMD? Is that what happened? That was my first question. And my second question was, I mean, third day we are doing a plasty. It's not often that we have our interventional radiologist or a vascular surgeon bold enough to go there and start doing plasty. So that was another concern, another interesting aspect of your case, I thought.
Yeah,
Yeah.
I can answer them both, Santosh. I did both the procedures for this patient. So the first thing is, yeah, we would routinely ultrasound intraoperatively, but when we sort of reperfused this kidney, it became pink, but it didn't have that fullness that you feel with a good graft. So it was a BD donor and it was making urine, but it was very flaccid. So, and there was a big main renal artery, and then there was an accessory artery. Both of them were decent, but the main renal was at least 2 or 3 times the size of the accessory. So I thought maybe there might be something there just based on that alone, even if we didn't have ultrasound. But when we ultrasounded it intra-op, we saw the lesion in the mid to distal renal artery, and then sort of had a, we had a bit of a think about it, and with all of his other issues he had, and the fact it was in the middle of the night and things, we decided that yes, we'd see how his renal function went in the next 48 hours because the kidney was pink, making some urine, but we'd be tentatively planning to do a balloon angioplasty. So it was diagnosed intra-op and then confirmed on our post-operative scans that it wasn't like a vasospasm or something else at the time. For the second question, we've got a pretty rigorous setup and technique that we do to perform our percutaneous interventions, and we will probably try and publish it. We've got a case series of 15 to 20 renal artery interventions on transplant kidneys over the years, collected over the years, ranging from plain balloon to drug-coated balloon to stents. The units had one case where there was a wire perforation, and I think in the case in the literature Asim presented, there was one wire perforation, but we've got a pretty sort of very, closely performed, very, very, what's the word? Like we perform it very carefully, and we have a very judicious technique, and we make sure that we're extra careful. But we're not, we don't sort of, I think we have the technology and the skill, and we have things such as intravascular ultrasound, I think, and we've had good results. So yeah. Not common, but we do it. Yeah. Amanda.
Thank you. I think it's really important not to try and disseminate the message that you can use live donors with FMD. We have never used them, and I don't think our nephrologists would ever let us near them. And I'd be surprised if other nephrologists are keen to support that, because often the disease is bilateral and involving other vessels as well. So we would certainly turn down any donor with FMD. And I think also it's important, a lot of those case reports, it's pretty small numbers, number one, and number two, the follow-up is pretty short. So, and number three, the ones where they have presented live donors, I don't think you've actually presented any figures on how the live donors go long-term, which would be a concern. So I think it's important not to propagate the thought that live donors with FMD should be used.
That's a good point.
Thank you.
Has anyone had experience with managing kidneys, deceased donors with FMD, and if so, have you used a particular technique or one of the ones that's been described in the talk?
We haven't, to our knowledge, had donors with FMD, but maybe some of the stenotic segments that we see, particularly in branch vessels of the artery, are variations on that we haven't quite recognised as FMD, but have gone ahead and angioplastied. But it's an interesting thought.
Yeah, I think when we have been doing our routine intraoperative ultrasound, because we get the ultrasound right on the renal artery, it's been quite interesting to see all of the, there is quite a lot of probably undiagnosed and not needing treatment, but there certainly is a significant percentage of patients that will have, or percentage of kidneys that have disease within the arteries that probably don't manifest as any pathology, and a proportion of those probably would down the track. Yeah.
Similarly, I think to resect, oh, sorry, Santosh, but I think to resect one segment of FMD is probably a bit naive. I mean, it's rare that you just get one tiny focus of it. It's usually that multiple beaded appearance. So it's interesting, those reports where they say they can just resect it and join it and get away with it.
Yeah, I mean, I think that it's a question of the underlying pathology. I don't know what if they were sent for histopath in those case reports, and whether it was just sort of atherosclerotic disease or true FMD, but yeah.
Yeah, and Animesh, can you hear me?
Yes.
All right. Yeah. See, we've had our share of FMDs here at the Royal Adelaide, both in the living donors as well as in the deceased donor. But by and large, in the deceased donor population, I mean, we often find it if we've had imaging for these patients preoperatively. Or as Amanda mentioned, you have the string of pearl-like dilatation of the arterial segments, and our usual modus operandi is resecting that bit of vessel out, and then using other bits, other grafts to reconstruct that artery. The more and more we look at the older donors in the living donor population, this often pops up, because very difficult to say whether it's atherosclerotic disease or it is pure FMD and so on and so forth. So when a 70-year-old person is donating to their partner who is also in the late 70s or into the 80s, we don't have much of a choice but take that kidney out. And usually if it is a unilateral FMD, then we do take the kidney out, provided there is no systemic other FMD type disease, after imaging. So it is not exactly a contraindication. I would put it more of a relative contraindication. Again, we got to weigh the pros and cons of what is available, whether is there any other source the patient can have as far as the organ goes to obtain an organ. So a lot of those sort of things will weigh into the actual decision making. But I often wonder how effective is plasty, because my whole like in your patient, you found the lesion, and by day 3 you've plastied it and it's like gone back. Now, sometimes I wonder, is it true FMD or was it just some sort of a clamp injury or those sort of things. So like in my head, it's like this: the older the patient, the older the patient, and if there is atherosclerotic disease, the plasty probably may not work. We may end up in stenting. Now, I'm curious to know, what sort of stents did you use? Was it a coronary stents or was it something else?
Yeah, we have these balloon expandable stents. They're not coronary, so they come in larger sizes we use them in other sort of peripheral vasculature, and some of them have drug-eluting technology on the stent as well. But that allows for a very precise deployment. Again, it's a thing that is something that we've learned how to use. It's not simple to put a stent in the renal artery, and you have to differentiate between a stenosis in the renal artery from a kink, because stenting that won't work. You just shift the kink versus stenting an actual lesion. In terms of your question about angioplasty, so within the vascular literature, like balloon angioplasty is the gold standard now for FMD lesions. If they're true FMD lesions, they have basically 100% cure of their lesion, because they have more of their disease and their media intima respond well to angioplasty. So this guy, he's had a 9-month surveillance and he hasn't had any recoil at all. And they have these intimal webs that there's no way to see that on the angiogram or even on ultrasound. And the only way you pick it up is the velocity elevation. They respond really well to angioplasty. So to the point that if you have talking just about normal individuals with diagnosis of FMD in their, young, in their 20s or 30s, and they have suggestion of an FMD renal artery with some hypertension, they do quite well to avoid them on long-term antihypertensive regimens to get plain balloon. Whereas the normal plain balloon angioplasty in like the traditional vascular atherosclerotic lesions have a very poor success rate. So yes, I think FMD is a very different pathology in its but there may be an overlap in a proportion of patients where you don't have the same response. This patient we don't have any clamps on the renal arteries. So we knew this was going to be a true sort of de novo lesion in the kidney.
Thank you. Asim, in your literature search, was this one of the large number of patients you had as a unit-wise, or are there other units around which have even bigger numbers of these FMDs?
I mean, I could only find that many number. The largest case series, I think, was about 11 patients with FMD diagnosed in living donors, but there haven't been many case reports, and I mean, I'm not aware of any other institution. I mean, if they have not published with intraoperative diagnosis and simultaneous treatment early on using a vascular intervention technique. Yeah.
Yeah, thank you.
That was all we had, and could probably finish early if there wasn't any other questions from anyone from the floor.
In fact, I was wondering what everybody thought about having universal CT imaging for all patients who come for an organ retrieval. It's like in this second-hand organ market. When I buy a second-hand car, or when I buy a second-hand house, I would like to know everything about the car or the house I buy. So wouldn't we want to know more about the anatomy of that organ system? And I find it it's something which people by and large have not accepted or made it a regular fixture. Everybody talks about we have ICU issues, transporting the patient down for a CT imaging and so on and so forth. I sometimes wonder whether is it best practice. It would be part of best practice that this CT imaging of the chest, abdo, pelvis in all donors should become mandatory. I'm not sure what the others think, irrespective of organ system.
Yeah, it's a good thought, Santosh. I don't know if we can get it across the line, but it would be helpful in lots of cases, wouldn't it?
It does, Amanda. In fact, here in Adelaide, we have been going at it for the last 2-3 years. And the surprising thing is when the liver and kidney guys, we talk about it, nobody does it. But when the heart lung guys calls from there saying, if you want a CT of the chest or the coronary, straight away the CT is done. And invariably the cut stops short of the upper pole of the kidney and still will miss the, the too few extra cuts below. So it's an ongoing issue we have been having, I think. But most of the Donate Life coordinators are sort of primed now. They are of the opinion that yes, it does make sense because we show them on table. This is what we are, facing as far as how the in fact just last week I had a kidney that came from interstate. It had 3 arteries, 2 arteries coming just off the SMA. I think it was from Sydney. I forget who retrieved it. And the lower one is just coming off the bifurcation of the common iliac artery. Now, if we did not have any imaging, the patient had an imaging because it was a trauma patient, so he had imaging. So we knew that the 3rd artery was coming off there, and therefore the person retrieving it could go on down onto the common iliac, external iliac area, and then perfuse the entire, all the organs. So the placing the cannula itself, they could plan it accordingly, and I could plan. Because right kidney was not usable because it had lacerated or not perfused, and therefore I asked for a graft, and the surgeon who was explanting it decided he will send the whole aorta and the IVC, so it worked well. So I used the whole thing as a arterial and IVC conduit, and it did well for us. So imaging definitely helps, is my thinking, and I hope that everybody, and the more I speak to people, everybody seems to agree with it, but somehow it has not really changed in the usual pattern of work.
I think Michael had a question.
Hey, Animesh. Sorry, I missed most of your talk. I'm Michael, one of the transplant surgeons in New Zealand. I think that's a good point about getting imaging. I know that in Europe, a lot of it's mandatory. All the donors get a CT scan of the abdomen and pelvis before they come for retrieval. And I think, like Santosh said, you can save a lot of money by doing a CT scan versus sending a retrieval team and spending time to retrieve an organ that's not usable. And also saves a lot of hassle for the retrieval surgeon inadvertently damaging renal arteries. That's kind of accessory or the lower pole that they don't know about of the iliacs. Imagine that if you didn't have any imaging, your cannula would not be perfusing the kidney, and you go, oh, how come it's not perfused? You say, yeah, I think the imaging is definitely helpful. And yeah, but like you said, it's when the heart surgeon says for a CT scan, they get it the next hour. When the abdominal surgeon wants it, it's probably get done within the 2 or 3 days if you even get one.
So, sorry, I was trying to raise my hand here, guys. It's Marcus, one of the HPB surgeons. What do you think about that, Jerome? Jerome left.
I think he might have left. I think, I definitely appreciate CTs, especially for the multi-organs. It really helps plan, particularly for the pancreas and liver, any aberrant anatomy. And I think aberrant anatomy is more common than normal anatomy, but because New South Wales covers such a broad area across many peripheral hospitals, there's, I think, a lot of challenges in trying to consistently ask and be confident that the CT has been performed by the time the retrieval comes around. That's been my experience. But I always look for it.
I tend to do as whenever we can, we do, and we push for it. And we have found interesting things. And it's because we fly to Tasmania, and if we fly there and you have a CT scan, you have the result, the liver is no good, so you avoid, wasting $50,000 on a trip.
Yeah, in fact, if I can just add on to that, Marcus, we recently had a DCD some 120 kilo lady who was going down the DCD pathway. We were asked to go and retrieve. Now, I do ask for the CT scans, especially if I figure out that it's going to be a difficult explant. And it so happened this patient also had a sharpnel inside the abdomen, and so, and we had IV drug usage and all sorts of things, So in a way, we could plan exactly what to do and how to approach this particular patient's organs. And then again, during COVID, when COVID started off, we were using CT scans on a regular basis. One of the things we found was we had a patient who had a CT scan. The first CT scan on admission to the hospital showed good kidney, good perfused kidney. 2 weeks later, patient became a DCD donor. Asked for another CT scan. CT again showed well perfused kidney. But it just so happened that looking at the numbers, something did not look right. The patient was not making urine. So this is actually contrast from the first CT, which was still sitting there, and the patient actually was sitting with a dead kidney. And this was before we started looking at all those counts and all that, as far as the dilution counts and all that stuff for COVID. So we avoided going for this particular retrieval, and therefore less exposure to the team. So yeah, I think Marcos, I think if everybody is happy, I think we should via animation and Handu, we should probably write it, advise TSNZ saying that this is something that we should make mandatory as far as organ donation goes in Australia and New Zealand. What do you think, Marcos?
I think it's a great idea, and we have tried to push this in other meetings, but it's quite hard to get everybody on the same page. But if the college, if we part of a team, if we endorse that, and then we can at least be heard somehow. I don't know if that's going to happen, but at least we put our word there.
Okay.
That's the same thing that we have the issues with, with doing the early retrievals or whatever. It's always a pain,
The group that you'd raise it to would be different in each state, wouldn't it?
Yeah, it should be done by the Donate Life as a preliminary, as a minimum standard, as best practice, and I think that's something that could happen. I think if all the surgeons decide, then it will become standard. Because the problem is if a whole bunch of surgeons do not agree, then there is a concern. But if I mean, the more and more I speak to people, almost everybody agrees on this point of yes, we require imaging. Then and when we are like as Marco said, it's $50,000 versus one CT scan, which is very small in the in the larger game.
I think Amanda wrote that most surgeons would love a CTA. Yeah, she is right. We always love to look at. We're gonna face.
Okay. And thank you everyone for some very interesting points. And I hope the presentation by Dr. Asim Khan was informative, and hopefully we can put this into a publication format before the end of the year for publication.
Many thanks.
Thank you very much.
Okay.
Thanks anyway.
Thank you.
Thanks, everyone. Thank you.
Bye.
Cool. Thanks, Asim.
Thanks, Ilmesh. I'll see you
Doing
tomorrow.
well. Yeah. Okay.
We have to consent the patient for tomorrow, isn't it?
Yeah, I can do it. They're here today, I think.
Okay. All right. I'll see you in the morning.
I'll see you tomorrow. Bye.
Thank you.